Ready.
Okay.
Okay, so follow up on hypercalcemia this week,
Yeah, hyperparathyroidism today. So our objectives
which are
are very. Can you focus in on that?
Yes.
technologically we're working with an updated smartphone and a
That's
laptop that doesn't communicate to a TV that won't turn on.
We could just carry the phone over, but no.
No,
Yeah.
I got it.
Understand management of hyperparathyroidism in your own clinic. In other words, reduce referrals. That's one of our objectives. Know when to refer for surgery, and then understand that when they aren't appropriate for surgery, what you can do for their treatment. Okay.
Yeah.
Should we start with a case?
Sure.
So we
Absolutely.
can kind of think about it. So 68-year-old man presented for routine follow-up, and his corrected calcium was 1 milligram above normal. So you got a PTH that's 3 times the upper limit of normal. Total vitamin D is 28, which is low. He has diabetic nephropathy, which has been stable for years, and he has an estimated GFR 50. Normal serum phos. He's got a total protein that's just mildly elevated at 8.5. What's the next best step for this guy?
Ooh, that's a good case.
Got all the
It's got everything.
So, this guy's presentation was pretty typical, right? I know at least when, we had the overhead projectors, didn't have this great technology.
Oh yeah,
that,
like last year.
yeah, I was taught stones, groans, and psychogenic overtones, right? But really,
This is how people.
present, right? And 80% of them wind up being a single adenoma. So the ones that have hyperparathyroidism, most of them are adenomas, and it's the 3rd most common endocrine disorder. It affects up to 3% of the population. So something we should know about. And the quote asymptomatic person is most typically what shows up through the door.
Right. And those are the people that I see referred, and they shouldn't be referred, because if they're asymptomatic, and we'll go through what those symptoms are, but if they're asymptomatic, watchful waiting is fine. They don't have to see endocrine, they don't have to do anything, and you just need to monitor them. So.
I think, and so I throw the air quotes up for asymptomatic. So
Correct.
the classic, if you wait for classic manifestations of disease, you're waiting too long. And so what would be some things that you guys would think about to ask? I usually wind up... measure, yeah. I usually wind up doing...
There's a workup.
I usually call the lab, add a couple things on, and then I usually schedule a phone visit to follow up with them. Because this is something I think is fairly... You can kind of...
Right.
Say, well, you had a biochemical abnormality, I've gotten this additional testing, and this is what I'd like to know, and you have questions. So what do you want to know, and what do you want to order?
So if we already had calcium levels and parathormone levels.
Yeah,
Yep.
so corrected calcium.
So in the corrected calcium, because if your protein is high, if your albumin is high, you can have high calcium. So you can probably check ionized calcium just to make sure that there's true hypercalcemia.
Yeah.
And then you check vitamin D levels.
Good.
Correct.
Yep.
That's the most important test.
Correct.
And then maybe phosphorus levels. So.
Yep. Now I'm going to put in a little caveat, and this isn't very evidence-based, this is more based on observational studies, but there are women in particular, this observational study looked at women with high PTHs and normal calcium who always went on to develop osteoporosis. So sometimes even just with a normal calcium, I think you got to kind of be watching that kind of thing.
Yeah.
So it's kind of odd. A normal calcium hyperparathyroidism is something you want to watch for too.
So you mean to say they need to have like regular DEXA scans done?
Correct.
Okay.
Correct.
Yeah. So that's something I want to get on the phone.
And we'll get that on everybody.
Is fragility, like do they have fractures?
Right. Vertebral in particular.
Yep.
And then another little pearl of this is that hyperparathyroidism will affect the bones of the radius first before it affects other bones. So in a hyperparathyroid patient, you may not want to order your normal DEXA, which is your lumbar spine and your femur.
Yeah.
Not a radius.
Yeah, so you're going to be able to pick them up sooner. You pick up osteopenia in them, bam, send them off to the surgeon. Don't wait for anything else. That way you're going to prevent, spinal and hip fractures that are going to follow. So.
Yep. So good fracture history, because sometimes people will fracture or had an atypical fracture and they don't. I actually had a guy today that came in and he had foot pain, and he's a big, huge, hulking guy, and when he sent me the note to come in today, he thought he had plantar fasciitis, but it was actually like ankle pain, and then actually he broke a small bone in his foot. And then when we were talking to him, he'd done this before, and so he just didn't say it, and so you have to think, maybe ask.
Yeah.
And it made me think about, geez, we maybe should get a DEXA in you because it is very atypical for you to be breaking feet
Absolutely. That's
that easily, just
Yeah.
spontaneously.
Yeah.
And the DEXA changes your management.
Yeah.
Um,
I think, and this is never mentioned in the literature, but I actually kind of like to do a chest X-ray because then I can pick up vertebral collapse that people may not be complaining about. That would change that too. So.
Absolutely. For symptoms, what symptoms would you want to know?
Constipation,
Yeah. Fatigue,
fatigue.
muscle irritability. The problem is when we're seeing people now, that are
Yeah.
their calcium's it's 10.8, and who doesn't
They're
have a little
tired.
fatigue and irritability, and their muscles ache now and
And
then.
they're irritable.
Yeah. So it can be hard to tease out, but
Yeah.
I think if you're really, really convinced that they have subtle symptoms, that's actually an indication for surgery. But I would be really convinced. But I think sometimes the point is you have to ask because you might miss it. And then,
It's hard to measure improvement, and so it's hard to and pre and post in the neuropsych symptoms. But I think that's actually where you can get a lot of benefit. And if I have an older person with some, early dementia, I totally am going to send them.
yeah, exactly.
So I think it's worth it. It's a really low risk surgery. I mean, this article is really good about pointing that out. Very low risk. It can be done under local anesthesia. All those things, and even the most frail elderly are surgical candidates for this procedure. Think of it almost like a cataract surgery, as far as that. So unless they're like bleeding diathesis or they're refusing surgery, I think they need surgery when they have symptoms.
Yeah, absolutely. And I agree with, especially in the elderly, because they're the ones that are going to have the osteopenia and
That's right.
osteoporosis. They're most at risk for fractures, so
Yeah.
they're the people you want to operate on the most.
Yeah.
Wouldn't they biopsy every parathyroid gland when they?
It's interesting, and I can't
Because-
say I'm a surgeon, but actually, they've shown, there are no strong recommendations for doing, you can do radionuclide studies and those kinds of things and pick up which one of them has
Most
the
likely.
adenoma. But they actually compared that to surgeons visually looking at the glands, and 90% of the time they can pick out the affected glands. So there's a lot of surgeons that aren't doing that kind of workup. That's a good question.
When I did endocrine, a lot of patients who had adenomas, they did biopsies, and they were so small that they took out every 4
Yeah.
glands. and
Oh, that's a horrible way to live
yeah,
too.
So they were it's a surgery is an important thing, but sometimes mishap happens, and
Right.
after they remove all the 4, it's
Right. The article said 85% of the people have one adenoma, one gland affected. And so, you gotta think that most of them are only gonna need one, because living without a parathyroid is just as disastrous.
You're in more trouble. Yeah.
But they do, I think almost all surgeons do PTHs interoperably, because the half-life is what, 5 minutes
It's like
or
5.
something?
Yeah, because if you
Crazy.
think about it, calcium regulates everything. It regulates
Right.
your conduction system in your heart, it regulates muscle contraction, so
Right.
it's very short-lived. And so,
So you can do an interop PTH, and that drops to normal, you're good. You're
Yeah.
golden too, so I think that's another reason, they can do that.
yeah, because I hate to admit this, I was around when intraoperative PTH started coming around.
Yeah.
And
Yeah.
before that, you would go and biopsy. They had to find all 4 glands, and the parathyroid glands have the unique characteristic of they can be anywhere they want. And the problem is they're anywhere they want in the head and neck area, which is a lot of sensitive
Yeah.
structures. And sometimes they'll even go in the chest.
Yeah.
And so they were looking for all these things, but now
Right,
uh,
kinda cool.
it's kind of cool. You can just measure it. It's a lot easier. And they did talk in the article about giving a radio tracer
Right.
preoperatively, because the goal.
Then they got a little handheld thing, that's
yeah, a
kinda cool.
Geiger counter.
It's kinda Star Trek.
Yeah.
Oh, that's it.
Take that out. So they could do a unilateral neck dissection, which if I'm the patient, boy,
That's nice.
amen, that's what I want. And then do my intraoperative PTH, because it's a lot less invasive.
Right. I do think we missed a couple of the indications for surgery still, as
Yeah.
far as, it's not, I don't know, some of these things aren't necessarily symptoms, but they're indications.
Younger patient.
Younger.
Good,
Why
less
why
invasive.
younger? Why do I care? We just talked about how the elderly are the ones at risk for, you know, these horrible fractures and stuff. Why
You
young?
don't want them to get there.
Correct. They almost, even if they're asymptomatic, I believe that indication of being younger is to go to surgery, because after 15 years of even mild hyperparathyroidism, you have all the bone findings of that. So, good. What else?
Any kidney disease,
Kidney disease. Yep.
Good.
stones,
Yep.
history of fractures,
Yep.
history of mild symptoms with abnormal DEXA scan
Yep. Good.
And anybody that has symptoms.
symptoms. Yeah.
Yep, good. Yeah, those are the big criteria. Gosh, anything to say about surgery or?
I don't think so.
I think 5% of the time they have to go back,
Yeah.
which is better to go back than to be rendered hypoparathyroid.
Right.
Um,
Because we don't take care of that. We can't treat that.
no, it's very difficult to
But
treat.
that the calcium level changes, and then that becomes tougher to treat.
Right.
at that time.
Yeah,
Disastrous.
they're basically dependent on ingesting large amount of
Ingesting.
calcium
Right.
to maintain their serum calcium.
And they're not asymptomatic.
Yeah.
in doing that. Would you consider calcium excretion in the urine, like high calcium excretion, an indication for surgery?
I agree. I wasn't in the article. I don't know if I missed it as I'm
it
sitting.
was not,
Okay.
but I think it should be.
I have always kept it in the back of my mind, and stones are becoming, for unclear reasons, more common.
Yeah.
And I think if you had a calcium-containing stone, usually, you wait for
Two-
two stones.
two stones.
Two stones to
Right.
work up.
Stones.
But if you had 2 stones, and I found out you had hyperparathyroidism, I would be recommending you have
Yeah.
your parathyroid worked on. I think
Says a
it'd be-
person who's had a kidney stone.
Yes,
has
I would
suffered
put
that
it
way.
under the symptom bucket. The emergency room visit and all
Yeah,
that.
that pain will drive your.
So I agree.
Yeah.
And I think we mentioned this last time, but before I would make a referral, I still check the calcium and creatinine ratio.
Yeah.
Just to be sure. Because remember, the people that have the familial mutation will have a higher PTH, but they're not dumping calcium in their urine. And there were lawsuits because these people were operated on,
Right.
and their
And they don't
neck,
get better.
their calcium's still elevated. And they don't feel any different because they were asymptomatic. And
Yeah.
well, it's somewhat true. I've heard that you can't make the asymptomatic patient feel better.
Huh.
But I think
even
sometimes
placebo.
no, but sometimes there are
Oh.
reasons to still intervene on the asymptomatic person.
Yeah, exactly.
Also, medical therapy. So the very frail. But what do we have to offer them?
Calcium, vitamin D. I mean after parathyroidectomy, but
Oh no,
but
like
vitamin-
so somebody that can't have surgery and has hyperparathyroidism.
So we're treating the kind
So
of
we-
this
and-
almost the really extreme. not that-
bisphosphonates.
Bisphosphonate's good.
Is it bisphosphonate? What's the goal of using the bisphosphonate?
To decrease the resorption.
Yep.
Uh,
Is it going to
And
change the
development.
serum calcium?
I don't think so.
Yeah, it's not going to change the serum
No.
calcium.
So you said we're giving them calcium. Is that?
No, that's
so are we giving them calcium?
no.
Yes.
I mean, if they have osteoporosis
Right.
or osteopenia, then along with vitamin D and bisphosphonates, then you give.
Right.
But if they don't have that evidence of osteopenia or porosis, I don't know we need to
Yeah.
give.
I actually you can give it because actually for some odd reason, it's still if you don't, then their PTH can go even higher.
I mean,
And then
is
we're only
that-
talking like 800 milligrams a day.
Because remember,
so-
they have a driver
Is
that's
this
taking calcium
Right.
from their bones and dumping it out
Right.
of their body. So they need calcium to be
Yeah, so
put in.
actually you do. It's weird. It's counterintuitive.
But is for symptomatic people or asymptomatic people?
Yeah, these are that's a good question. And I don't know if I know the
I
answer
would-
to that.
I would
For my
say-
asymptomatic, I haven't necessarily given them calcium, but
No,
Yes.
no, not if they're asymptomatic. And if this is somebody that's so frail that because if you're making the case, we
That they
have
already
we
have
have
osteoporosis.
osteoporosis, we just can't operate on them. So what can we do medically
Yeah, if
in
it is
place of operation?
osteoporosis-
So
No,
we can
like if a patient has kidney stones, calcium
Yeah.
kidney stones, would you
Yeah.
still give calcium?
depends on what kind of kidney stone, right?
Yeah, calcium stones and
what if they
calcium
got
Oh.
calcium
phosphate.
stone?
And it depends on the cause, right? So if it's a calcium oxalate stone or
Calcium phosphate stones.
yeah, no, then no, definitely not.
Yeah.
Okay, we gotta get out of that rabbit hole. We're way off.
RK's putting us on the spot
Yes.
on the YouTube.
And it's not just the broken cooling towers and the bad technology, but I'm sweating.
That's right.
Jesus, I feel like I'm a resident again.
I feel like an intern.
Oh no. So cinecalcet, what about that? How do you guys feel about that?
The cheating effect.
Yeah, so
Yeah.
It basically mimics parathyroid hormone, right?
Yeah.
Or I'm sorry, mimics calcium. And
Calcium.
so it goes to the parathyroid hormone and says, hey, stop producing PTH.
Right,
And,
it kind of works on the receptor.
but interesting, I think, should we do I think that was one of our questions.
That is one of our questions, yeah.
So cinecalcet, I learned this from this article, did not change bone mineral density. Is that surprising to you guys or not? And so if you
Yeah, no, it didn't change fracture risk or.
yeah. So is that surprising to you guys? It was surprising to me. I had to stop and think about it. So if you have this elderly, frail person who has a hyperparathyroid state that you can't operate on, and they have symptoms or they have fractures, you need to put them on a bisphosphonate and the cinecalcet. Wow. They're not happy. Two very expensive
Right.
drugs. Well, I guess bisphosphonates are cheap now, but
Cinecalcet's really expensive.
yeah. So they're mad at you for at least one script, and then the other one they have to sit upright and all that other stuff.
Yeah.
So is that surprising?
I don't. Yeah, I don't know
It
if it
shocked me.
directly acts on. It doesn't act directly on the bone, so
Yeah,
you're not
exactly.
gonna. You're not inhibiting the rank ligand or anything like that, so it's not gonna affect your.
Exactly. Yeah. So
It's
yeah.
not inhibiting your osteoblast, right?
Exactly.
So, yeah.
So when we
Yeah.
stop to think about it, it actually does make sense that we did not see a change
Yeah.
in bone mineral
But you're right,
density.
and it's not so bad that you had to think about it because actually I saw a lot of little studies
Mm-hmm.
trying to figure out if it could help with it. You know, because in some parts you're like, well, it's helping decrease the activity of the parathyroid hormone, you know, kind of thing. So, but again, it's just it's the connection or the communication with the osteoblast. So
And you still have excessive PTH
Yeah.
out there that's rolling
Yeah.
around.
Yeah, but
it's
my point
Band-Aid.
is,
It's
you know,
masking, like
yeah.
you said.
you're just masking
You're
the
masking.
production,
Yeah.
but you're not stopping PTH production in the sense that adenoma is independently producing
That's
PTH.
right.
Yes.
Even though you're just giving calcinate, it won't suppress to the extent that it will
Right.
stop resorption from the bone.
Right.
Exactly.
It's an expensive, imperfect drug.
For very
That's
select
nice,
cases.
yeah.
Interesting, they mentioned hormone therapy on here, but I was like, boy, that's really a
But you know what I
select,
thought about? I mean,
case.
if they suggest hormone therapy, how about raloxifene?
Oh, okay.
I'm wondering.
Yeah.
I think a SERM, you know,
Mhm.
those serum
Yeah.
estrogen
Receptor
modulators,
modulators.
yeah, might work.
Yeah, it might.
If you can't, for some reason, tolerate a bisphosphonate, that would be a reasonable thing. I don't think I'd ever give estrogen, but I think a
SERM would be a
raloxifene
reasonable.
would do it.
Yep.
Yeah.
Okay, the other ones we had. So the vitamin D in this person is low, and the PTH is high, and they have an elevated calcium. What should we do?
Give vitamin D first,
Okay, good.
and then recheck after a few months and see.
Good. What do we
Good.
expect to happen?
I mean, what's happening is because of your low vitamin D levels, your calcium is low, so your parathormone is acting high now.
Yeah.
Now, if your vitamin D goes up, your calcium may get better, so your parathormone may go down.
Do we expect it to get better for this case? So we had the case
Yes.
again is this.
Yeah.
48. Yeah.
Probably.
Yes. Treatment is vitamin D.
So
And
Well,
we have
but-
to trial if it does not respond.
So the PTH is really, really high. So I would recheck the PTH.
We'll
and
recheck
everything.
again.
three
I'm
times
not
the upper
sure.
limit.
Yeah. So it's possible that you have, and if somebody is that vitamin D deplete, did you expect them to be hypocalcemic or hypercalcemic?
It should be high. It's not that
Yeah.
bad. It's just 28.
Yeah. And
Yeah.
so what do you
But-
have?
His calcium was 1 times the upper limit of normal.
Yeah.
So it's still.
So you would expect a low vitamin D state to be
Yeah.
associated with high PTH and probably a normal or low
normal
serum
fat
calcium.
calcium.
Yeah.
Yeah.
So what you're going to probably do is make this adenoma worse. Because you've given it the fuel to absorb more calcium because you're going to replace the vitamin D. Does that make sense?
So this guy's vitamin D is 28, and I think the normal vitamin D at the VA is 30.
30.
What are you
Yeah.
aiming for? Is he vitamin D deplete? What are you aiming for?
Above 30.
Yeah. 50 is the literature for treating a hyperparathyroid patient.
Yeah.
And,
then
and you
there's-
know, they're all over the place, but if you go to Creighton, you have to say it's like 50.
Well, there's two different.
Right? Those
Yeah.
vitamin
Yeah.
D.
There's
Yeah,
two
I
big
know.
societies, and there's 40 out there.
Yeah.
I can't
Sometimes-
remember which one. The other one is 50.
Dr.
Right.
Becker is happy
Yeah.
with
Oh, you
40.
should see the endocrinologists fight at the societies over vitamin D level. But anyway, hyperparathyroid. 50 is what you want to
Yeah.
Because that you want to almost kind of tip the curve over a little.
So this person might get worse, and so you might tell
Yeah.
them if you develop symptoms, I would definitely remeasure the calcium. I
Yeah.
would do the loading of the vitamin D, and then arrange for a recheck on their vitamin D and their calcium and their PTH, and probably follow up a phone call. And if they're getting worse, then you might have to consider surgery.
Yeah.
And then the other indication for surgery that this person has is a GFR less than 60.
60. Yeah.
So how do you differentiate secondary from primary hyperparathyroidism is really the question. Because as your kidney function falls, your PTH normally goes up.
But is it
So,
like 3
and-
times the upper limit of normal is still, I don't know,
So
it
what's
goes that
the
high.
what's the mechanism in chronic kidney disease is the question of what's driving the PTH.
Yeah.
So what's driving it is as your kidneys fail, you don't make vitamin D. So you don't make vitamin D, you become hypocalcemic, and so that triggers parathyroid hormone to be released. And as a trade-off, you reabsorb calcium from your bones to keep your serum calcium high.
And you
So in a
drug your-
chronic kidney disease patient, you wouldn't expect them to have a high serum calcium. You would expect it to be low. And that's why we give them things like calcium acetate, because what we're doing is we're saying, take that calcium acetate with the meal because the calcium will be absorbed and the acetate portion will absorb phosphorus, which will be secreted in the stool. And so you're removing the high phosphorus that comes from eating it. And the other thing is these changes don't typically show up until you're about stage 5, advanced 4 to 5. So it would be too early. So somebody with a GFR of 50 wouldn't expect these changes. And instead of being hypercalcemic, you'd expect a normal or a low calcium.
Yeah.
So that's how you'd sort it out.
But
So-
GFR less than 60, I heard you can have these changes early. So they usually recommend you to replace vitamin D when if you have vitamin D.
Oh yeah, and that
So-
might be contributing to this person's low vitamin D. Not only is it just very common, this person also
This
has
guy's
reduced.
got a multifactorial.
He should
Yeah.
be
I
a
love his
veteran.
taste. He should be. I bet he is.
Yeah.
But at that advanced stages, do you replace with calcitriol?
Yes, you do replace the vitamin D, and
If you don't
D3.
respond to
Yeah.
vitamin D high doses, then
Yeah,
we
you
go
do
for
it.
calcitriol.
Yep, exactly. Yep.
The other thing I like about this case that you got to always think about too is his trophies a little high.
That concerns me. You know,
Yeah.
in the sense of yes, we are relying on diabetic nephropathy and GFR 50. If you have high protein
Yeah.
and high calcium levels, I will go for evaluation with SPEP.
I
Yes.
think you
Yeah.
always have
Multiple
to.
myeloma.
Which
Yeah.
there's now a tab you can add it on to the blood in the lab without even calling them.
Wow.
So add it on.
Yeah.
Where are we?
We're done.
PA.
Yeah. Steve Jobs has been reincarnated.
At the VA.
Yeah. You